and we will move on with Professor Heimann's talk on current indications and limitations of intraocular biopsy.
Thank you for giving me the opportunity to talk on indications and limitations of intraocular biopsies. In Liverpool, we are one of 4 adult ocular oncology centers in the UK. We usually see about 1,000 new patients a year with a little dip during the COVID crisis, about 300 melanomas per year, and we perform between 60 and 90 biopsies per year. Regarding the technique, about 90% of our cases are now done with transretinal biopsy and about 10-11% with transscleral biopsies. Regarding the technique, the transretinal biopsy is a 3-port vitrectomy setup, but no vitrectomy. We go through the retina into the tumor, remove tissue, check that we have enough cells that we can see, and then remove the ports without any tamponade or retinopexy. For the transscleral technique, we perform a scleral flap, then a cut down to the choroid. We use the Essen forceps to get material out of the tumor, and then we use tissue glue to seal this tunnel for cells that they don't escape. We check for cells, and after we sealed it with tissue glue, we put a plaque straight on to minimize the risk for seeding. We do histopathology and genetic analysis on all cases, and these are our indications that I want to show you in more detail with pictures. The most important indication is prognostication. So we know this is a melanoma based on the clinical diagnosis, but we want to know what is the prognosis for metastatic disease. Now, if you don't do a biopsy, you can put in the risk factors into a risk predictor. The adjusted life expectancy of that group is there, and you know it's a malignancy, but you don't know is it a high risk or low risk malignancy, so your prognostication for survival would be somewhere there. If you do a biopsy and have a disomy 3 tumor, you will get this result. You put all the individual risk factors, including cells, in there, and you can see that this patient does not have a higher risk compared to the general population. With monosomy, obviously this is different, and you see how these prognostic curves vary depending on the biopsy result. Now, at the moment, it may be for information only, but we're at the sort of really new step of having treatments now beginning to work for metastatic disease. So the next step likely will be to identify the high-risk patients for neoadjuvant treatment. So watch this space. I'm sure it's going to change very soon. Prognostic or diagnostic in small tumors, Rumana already talked at that. We are quite aggressive with the treatment because no specialist on the planet can tell you is this a melanoma or not. And if it's a melanoma, is it monosomy or disomy? And if it is monosomy, can you make a difference with treatment? We think we can make a difference, as Rumana pointed out in her paper, that smaller tumors with high-risk characteristics have a better survival than large tumors. So treating them early possibly is your only chance to prevent metastatic death in these patients. And this biopsy, for example, in that patient is a small melanoma with monosomy 3. The next group of indications, in about 11%, is diagnostic. So all the experts in the world every once in a while see cases where they really have no idea what this is. And this is one of those cases. This diffuse swelling around the optic nerve head, no other symptoms, no other diseases. We really don't know what this is without a biopsy. Turned out to be acute myeloid leukemia, so possibly a life-saving biopsy. We all have these odd cases, a pigmented tumor, but it seems to be not only in the choroid, but going into the retina. Lots of exudates, very not typical for any type of melanoma. So is this an adenoma? Is a melanocytoma breaking through? A biopsy will tell you this is a choroidal melanoma. The next group, in about 6%, are metastases of unknown primary. Here you can clearly see these are metastases, multiple in the other eye as well. But in about 30% of our cases with metastasis, we have not a known primary. And 2 problems about this. Number 1, metastatic disease in the chora can grow very, very quickly and affect your vision within weeks, really. And number 2, it can be really cumbersome and a lengthy process to do all the scans and screens to find out where the primary is. With a biopsy, you have the result in 1 or 2 days. So this turned out to be a breast carcinoma. So you shortcut the diagnostic circle. In lymphomas, you definitely need a biopsy for tissue diagnosis because any kind of chemotherapy will depend on the tissue diagnosis, so you can't do without it, and this is in about 6% of our cases. Now, what are the complications? No result is the biggest complication, so the patients are very disappointed. We try to get better and better, and we have no histology now in less than 5%, no genetic result in less than 10%. From the surgical point of view, a vitreous hemorrhage is the biggest complication and about 10–15%. Again, we try to get better and better, but this is not a problem we can eliminate. And even worse, a subretinal hemorrhage, this case of a 70-year-old man with a new tumor. The son had a choroidal melanoma, but this looked more like a metastasis. We weren't sure. We did a biopsy. It turned out to be a melanoma as well. There was a little bit of bleeding during the biopsy, but unfortunately it bled afterwards in the week later with a submacular hemorrhage. So you need to understand that this is a procedure that can cause severe problems, in particular in tumors close to the fovea. Retinal detachment is surprisingly low rate of this, in less than 1%. Severe but rare complications are tumor seeding. We haven't seen one in the last 10 years, but we've seen one in the early days of our biopsies, and endophthalmitis, which unfortunately happens perhaps once every 2 years in these cases. Again, we try everything to prevent it, obviously. So what are the limitations? Basically, your setup is the limitation. You need good surgical skills, and we're very fortunate that I work in a team with Karl Grunwald and Rumana Hussein, who are excellent surgeons and very, very good in doing these biopsies. The lab skills are really, really required. There's only a few cells there, as you could see in the video, and you need to process them in the right way. And obviously the pathology skills, without somebody at the other end being able to really interpret these cells and identify them and make a call on them, that needs special skills that you won't have in every hospital. Regarding the lesion, what are the limitations? Close to the disc is difficult because of the big vessels in the way. We try to avoid it, and we can do biopsies in these. You see the little biopsy site. And on OCT it is possible, but these are getting tricky. Regarding the size, approximately 5 millimeters in diameter, 1 millimeter in thickness, but you can't run away from them all the time. This even was a pregnant lady, desperately wanted a biopsy before she had any treatment being pregnant. We did a biopsy, turned out to be a melanoma, and after plaque treatment, you can see the biopsy site. Unfortunately, everything went well. And finally, the limitations are the psychological side of things, the impact on the patient, the risk-benefit analysis, is this really worth it, and the patient's choice, really. We never force a patient into a biopsy, it's always patient's choice. Thank you very much for your attention.
Great. Thank you very much, Hanno. There is a question in the Q&A. What is the thickness threshold to perform transretinal biopsy? And Jens answered from that it is they would like to have a lesion higher than 1 millimeter. Have you had biopsies in smaller lesions than 1 millimeter?
Yes, we had, and we have no cutoff point really. To be honest, if it's less than 1 millimeter close to the fovea, then we usually, in inverted commas, try to really discuss with the patient, is it worth it, and try to talk them out of it, to be honest. But we don't have criteria where we say, no, we won't do it. The patient has to understand what this is for. The patient has to understand the risks. And if the patient, like this pregnant lady who wants to do a biopsy on a pregnant lady and a tumor above the macula, no one, okay? So I put it on Carl's list or on Romana's list, and then they might not know that she's pregnant, and they just do it. So these are things that, I'm not saying we have no exclusion criteria. There are cases where we don't like to do it. I personally find the ones at the disc the worst, sort of the small ones at the disc with the big blood vessels. And if you think you have enough space between the blood vessels to go in there and as soon as you touch it with a cutter, you can see how the blood vessels go down to the cutter. And you think, oh my God. And I've seen during a different surgery, one of these blood vessels being nicked, and you don't want to ever see it again. So it's something that I really have a bit scared of, but there's no cutoff point. And I think Roman is analyzing our data on the very small ones, 1 millimeter or less. But we try everything. But as I said in the talk, less than 1 and less than 5 millimeters side to side, they usually go hand in hand. We hesitant, but we don't say no.
Romana just noticed that the smallest she has done is 0.4 millimeters. But this was this was
the way to do it is you have to lift the retina. That's a trick from Carl Gronwald. So you can't just go and cut because you're cutting retina. So you have to make a localized retinal detachment over the lesion, and then, like a vacuum cleaner, turn the cutter around and try to scrape it off the sclera, basically. But I would be lying if I say not a problem. These are things that you don't want to have 2 glasses of wine the night before. So these are tricky ones. Yeah.
My impression was in some cases of small lesions that when you go into the lesion, then it is so compact, this small lesion, that you tear the entire choroid. And I was really afraid that I will cause some suprachoroidal hemorrhage in this situation. But fortunately, I haven't had this complication yet. But I must say that you stated that you have a missed yield of approximately 5% in pathology and 10% in genetics. In our setup, I must say it's pretty much the other way around. We need less material for genetics because it extracts the RNA, and we probably have more than 10% failure in histology.
Yeah, a couple of points to that. Very good point. Number one is we used to do genetics only with histology because we don't want to take the genetics from a cell you don't know. So we always did, yes, it's a melanoma, and then the analysis. However, even in small lesions, sometimes you're almost sure that it is a melanoma, and you want to know, is it monosomy or not? So if we as clinicians say this is a melanoma, and the pathologist says, look, there's not enough material for both, make your call. What do you want? Do you want histology or genetic analysis? There is sometimes we go for the genetic analysis in this, really. There's a good question is how much material do you need? Another reason why our rate is getting bigger is because we talk to the patients and they're so disappointed when they don't get a result. So to our threshold is really our eyes, that we take out the biopsy specimen, we look at it, and you need to see blocks of cells in there with your own eyes. If you don't see them, don't send it off. Guaranteed it's a negative result. So you can then think, I either go in again, even if it's bleeding, I want the result, or you say, I call it quits here. But our threshold really is that you, as the biopsy surgeon, can see clumps of cells in that, as I showed in the video. This is what we're aiming for. The only difficulty is if you have a lot of hemorrhage in there, then blood will mask everything, and you don't really know how many cells there are. But I think our biggest driver why we get better results is the disappointed patient.
And may I ask on the technique, do you aspirate manually with a syringe? With a 3-port, or how do you do this exactly?
Yeah, very good question. I didn't have time to show all of this, but what we do is we have our normal 23 gauge setup, 25 or 27 gauge, and in the cutter line we put a 3-way tap. You cannot aspirate because all the good stuff will get stuck in the tubing and in the cutter. So the best cells are actually in the cutter. Okay, so the way you do it, you cut for about a minute or so, or until you see the first cells arriving or blood in your tubing system. And then you go to the 3-way tap and inject retrogradely the BSS to flush out everything out of the cutter. And we do that a couple of times. Okay, in this way, you get a lot higher yield. If you got it all in there and then try to, with a suction, to get it into the syringe, you get, I would say, 5 or 10% of the cells. All the good cells are in the cutter, so you need to retrogradely flush them out.
What kind of machine do you have to use that you use for this? I'm asking because the Alcon machine, it's not very long, the tubing, until you have the first connection line. It is about this size.
Yes, and this is why you need a good nurse to watch you. So the worst thing is if the good cell material goes past the three-way tap, then it's in the tubing, it's on the way to the machine. And then you have to aspirate that out of the tubing. So the nurse needs to watch until it's just about where the three-way tap is. And then you stop the biopsy. But if you see it in the tubing, I'm happy, because that means I've got a lot of material. The worst ones are exactly as you say, the ones that are like leather. And actually the worst ones are nevi to biopsy, because they're there for 15 years. They are like leather, and it's awfully difficult to get a biopsy out of them.
Thank you for your comments.
Mm-hmm.
I think you could go